Can you hear me?
Yes. Yeah, we're all set.
Okay, perfect. So welcome everybody. We are extremely fortunate to have Aaron Richterman and Eric Meyerowitz return to give us a first update on COVID-19 since their initial presentation a few weeks ago. I'm sure there was much to learn in the interim. So we are extremely grateful to both of them for putting together another talk on this pandemic disease. The code for today is COVID. As Jen and I were saying, it's unclear to me how that code name hasn't already been taken, but we got to do it. So go ahead and use COVID for your CME code today. And Aaron and Eric, thank you again and take it away.
Okay, thank you, Molly. Once again, everybody, I'm Aaron Richterman and my co-presenter is Eric Meyerowitz. We last spoke 2 weeks ago on March 25th, and our goal today is to walk through some updates from the COVID literature since then and to provide references for you to go into greater depth if you're interested. So in the last 2 weeks, we've continued to see an explosion of research on this subject with 1,566 papers related to COVID-19 indexed to PubMed and 560 preprints posted to medRxiv bioRxiv during that time period. And this is our agenda for today. We're going to start off by specifically updating some elements of our prior presentation before moving into new insights in virology, the role of the RAAS pathway in COVID-19, antibodies and immunity, a short summary of the still too few therapeutic clinical studies, an overview of the emerging importance of hypercoagulability and cardiac injury in COVID-19, the questionable importance of anosmia in case identification, some age-based considerations, and finally, some new reports on seasonality, surveillance, and contact tracing. Our first series of updates will be concerning transmission. And we'll start by going into some discussion about environmental viability. This is a preprint that was posted March 26th that complements the New England Journal study we referenced last time that evaluated environmental viability of the virus during experimental conditions. This study here collected 163 environmental samples near 13 patients with mild COVID-19 isolated in negative pressure rooms at the University of Nebraska. They found viral RNA on commonly used items, including cell phones, with 85% of samples positive, as well as toilets and in air samples. 63% of in-room air samples were positive, although live virus could not be cultured. This, of course, again raises the question of whether SARS-CoV-2 is routinely aerosolized and whether airborne transmission is important. However, if we consider the paradigm of influenza, both RNA and infectious virus have been isolated from both droplets and aerosols. And despite this, a large recent randomized study of surgical masks compared to N95 respirators referenced below in healthcare workers found no significant difference in incidence of laboratory-confirmed influenza. So this is another preprint posted on March 27th from a group in Hong Kong that additionally evaluated viral viability at various temperatures. You can see on the left here that virus titers remain high for up to 14 days at 4 degrees Celsius, but drop to undetected at 56 degrees Celsius within 30 minutes. This was an extremely timely study from another group in Hong Kong that enrolled patients from 2013 to 2016, but was just published in Nature Medicine last week. These authors sought to understand the utility of masks in preventing transmission of various respiratory viruses, including influenza, certain non-COVID coronaviruses, and rhinovirus. They distinguished between coarse droplets greater than 5 micrometers and fine aerosols with diameter less than 5 micrometers. They included 246 participants with respiratory symptoms and randomized half of them to wear a surgical mask. They analyzed a subset of about 50% who had confirmed positive testing for a respiratory virus, and then they captured exhaled breath particles and differentiated them as either droplets or aerosols. So the top figure relates to the coronaviruses and the bottom to influenza. And in the left panel, you can see that the viral load was significantly higher in nasal swabs compared with throat swabs. The middle two panels are recovered viruses from droplets, the right one being with masks. And you can see that there was a significant decrease in viral recovery with the use of masks for those patients with influenza. The right two panels correspond to recovered virus from aerosols, again with the rightmost panel being with surgical masks. And you can see that there was a significant decrease in the recovery of coronaviruses in aerosols with the use of masks. While this study was not done in the specific context of SARS-CoV-2, it very much supports the idea of using masks to prevent transmission from an infected individual who, in the case of SARS-CoV-2, may be asymptomatic. All right, so speaking of transmission and environmental contamination, this was an interesting case report published in Annals on April 1st of a 6-month-old infant admitted to an isolation ward because both parents had confirmed COVID-19. The infant was asymptomatic, but a nasopharyngeal swab confirmed a high SARS-CoV-2 viral load with cycle threshold values of 14 to 16. The infant remained asymptomatic and clinically well throughout the hospitalization. And despite this, viral RNA was identified on the infant's bedding, cot rail, and a table situated 1 meter away. Samples from a healthcare worker's PPE were found to be negative. This is further evidence of concern that children, even largely non-mobile infants, may be a potential source of asymptomatic viral transmission. This is a figure of the early experience of pregnant patients with COVID-19 at Columbia and New York City over a 2-week period in March, during which they implemented a universal screening protocol. Importantly, 14 women with COVID-19 were asymptomatic at presentation, of whom 12 were identified using the universal screening protocol, and 10 went on to develop symptoms during admission. This suggests that universal screening in this population may be appropriate when the prevalence of SARS-CoV-2 is high enough. This is an updated table then of anatomic sites tested for SARS-CoV-2 with references below. Since our last talk a few weeks ago, viral RNA has been identified in the urine, CSF, and pleural fluid. There's been a case series of 10 women and a case report of another that found no viral RNA in vaginal secretions, and one case report of a person who had a pericardiocentesis, but no viral RNA was identified. Additionally, this was a study published in Emerging Infectious Diseases on April 3rd from the Wuhan Blood Center. They screened all of their donations and found SARS-CoV-2 RNA in 4 blood donors, as depicted in this figure. 2 ultimately became symptomatic with fever after donation, and 2 remained asymptomatic. The authors did not evaluate for viable virus, and they destroyed all samples after identification. The importance of viremia and the possibility of bloodborne transmission thus remain uncertain. So let's move on to revisit the question of vertical transmission, about which 3 different papers have been published in the last few weeks. The first was a cohort of 33 neonates at Wuhan Children's Hospital. 3 of these neonates became infected, each depicted as a line on this timeline. Patients 2 and 3 had close contact with a parent who was ultimately diagnosed with COVID-19 prior to the child's diagnosis. But patient 1 was delivered to a mother with confirmed COVID-19, was quarantined immediately after delivery, and several days later had clinical pneumonia with a positive SARS-CoV-2 on nasopharyngeal and anal swabs. The authors report strict infection control during delivery, and they suggest the possibility of vertical transmission, although this is, of course, weak evidence for that, with nosocomial infection probably still more likely in this case. These are the other 2 papers published in JAMA with the accompanying editorial below. The one on the left was a case series of 6 pregnant women with mild COVID-19. Their infants were immediately isolated after delivery, and 2 out of 6 were found to be positive for SARS-CoV-2 IgM. Both were asymptomatic with negative PCR testing. The case report on the right was of one pregnant woman with mild COVID-19. Her infant was quarantined after delivery and had a positive IgM at 2 hours of age with a negative PCR throughout this course. Neither study did testing of cord blood, placenta, or amniotic fluid, which is a major limitation. And while IgM is too large to cross the placenta under ordinary conditions, and these authors hypothesize that this thus represents vertical transmission and in utero infection, IgM testing is very prone to false positive and false negative results, as well as cross-reactivity. IgM has also been shown to cross the placenta in inflammatory infectious conditions. And the accompanying editorial, which is below, also points out that the kinetics of IgM decline described in this case report on the right was extremely rapid and atypical for such infections. So it remains an open question. In summary, then, this is a new table put together by Eric showing various modes of transmission that have been investigated. On the left, you can see the source, whether RNA or live virus has been detected, and then mode of transmission and underlying human or animal evidence on the right. This will be available for reference afterwards. Next, we have one study to add as an update to our diagnosis slides. But first, as a refresher, this was a study we discussed last time that suggested a possible added benefit of IgM for diagnosis, particularly later in the disease course. This is another study published in CID on March 28th, also supporting use of antibody for diagnosis in certain situations. They looked at more than 500 samples from 173 patients with confirmed COVID-19 and tested them serially for antibodies and viral RNA from the respiratory tract. They unfortunately don't specify exactly which anatomic site in the respiratory tract they sampled. In any case, in this figure, you can see the timeline of the various testing modalities: RNA, total antibody, IgM, and IgG. And the redder boxes indicate a higher percentage of samples which were positive. The results suggest that right here, around 7 to 10 days after illness onset, antibody testing may be useful for diagnosis, particularly in the setting of a compatible illness and negative PCR testing, which starts to fall off at this time point as antibody becomes more positive. So next, to highlight a few newly identified risk factors for severe COVID-19 disease. One of the questions that came up after our last literature review was whether obesity was a risk factor for severe disease, postulated based on various clinical observations and anecdotes. This preprint, posted on April 1st, describes a retrospective analysis of 383 patients with COVID-19 at a hospital in Shenzhen. As you can see on the right side of this table, in a multivariable model that also included, among other things, age, sex, and a variety of comorbidities, the authors found that a BMI greater than 28 was associated with severe COVID-19 disease with an adjusted odds ratio of nearly 3.5. Looking at another risk factor for severe disease, this was a retrospective multi-center study in Wuhan published in eClinical Medicine on April 4th. They identified 34 patients with a median age of 55 who were asymptomatic at the time of elective surgery and went on to develop symptoms shortly thereafter while hospitalized after their surgery, ultimately being diagnosed with COVID-19. In the table on the left, you can see the surgeries performed on these individuals, all elective, with lower level surgeries being lower risk. And the figure on the right, you can see that there was a median of 2.5 days from surgery to the first evidence of symptomatic disease, that 44% went on to require ICU admission, and 21% ultimately died. All patients who died had level 3 surgeries. These findings suggest that surgery during the incubation period may be a risk factor for severe disease, and that screening asymptomatic patients prior to elective surgery, when elective surgeries are resumed, of course, may be beneficial depending on the local prevalence of SARS-CoV-2. Here then is our updated table of risk factors for severe COVID-19. I won't go through these again at this point, but the slide again will be available after the talk for reference. Finally, I want to share a few more robust analyses estimating the symptomatic case fatality risk. All of these studies account for both under-ascertainment of cases, which can bias the CFR upwards, and censoring in the case of prolonged illness prior to death, which can bias the CFR downwards. On the left is the Nature paper from our last presentation. In the middle is another paper published in the Lancet ID, estimating the symptomatic CFR in China, with the figure again stratified by age using slightly different methods. And the right is a preprint doing the same in Korea. All of these estimates are converging around 1.4% overall symptomatic case fatality risk. Risk in other locations will, of course, depend somewhat on the age distribution, health system capacity, testing strategy, and process for assigning cause of death.
All right, so we're gonna pivot to some other topics now. Last time we looked briefly at some of the basics of virology of SARS-CoV-2, and today we wanted to go a little bit deeper in terms of what is known about the steps of cellular invasion by this virus, since it's critically important to thinking about many of the investigational agents that are being studied for COVID at this time. Next slide, please. So I'm going to take a few minutes to describe how the basics of viral entry have been worked out so quickly by some amazing scientific groups around the world, and also take a look back at some relevant work that was done with SARS-CoV some years ago. So this study was published in Cell in February. Here, the authors arranged for a vesicular stomatitis virus to express the S protein from either SARS-CoV or SARS-CoV-2 and inoculated various cell lines. And as you can see, they showed that both viruses enter the same types of cells. Next slide, please. So in the same study, the authors analyzed the amino acid residues of the receptor binding motif of the S protein of SARS-CoV-2, which is the part that actually binds to ACE2, and they found that SARS-CoV-2 has the crucial residues to allow for binding to the amino acid to the ACE2 receptor, which you can see here. Next slide, please. So they also found that anti-ACE2 antibody significantly inhibited SARS-CoV-2 entry into cells. This is shown in this chart. So as you can see on the left, escalating concentrations of anti-ACE2 antibody have no effect on a control virus or on MERS-CoV. However, they inhibit entry of SARS-CoV and SARS-CoV-2. Next slide, please. Multiple groups have now shown the structure of the S protein and confirmed its binding to the ACE2 receptor for cell entry. So here, these authors, this paper was also published in Cell, and these authors have plotted the S protein structure of SARS-CoV-2. The darker red areas are conserved between SARS-CoV and SARS-CoV-2, and the green lighter areas are variable between the two viruses. Next slide, please. So ACE2 is expressed in type 2 pneumocytes in addition to many extrapulmonary sites, and this includes the nasopharynx, heart, kidneys, blood vessels, small bowel, among others. Next slide. So because of viral size of 80 to 100 nanometers, scientists believe the virus would have to infect endothelial cells after migrating from the primary site of tissue involvement, and then migrate further from the infected endothelium to tissues, to other tissues to cause multisystem involvement. So here in this recently published paper in Cells, these authors found that SARS-CoV-2 could infect endothelial cells and kidney cells, and that progeny virus of these infected tissues is infective in both settings. So on the right, they show that ACE2 is relatively strongly expressed in the proximal tubules of the kidney. Other tissues with ACE2 receptors were not tested in this study, but may be susceptible to SARS-CoV-2 invasion. Next slide, please. So based on the accumulating data that ACE2 or anti-ACE2 antibody can significantly but not completely inhibit viral entry into cells, scientists have proposed that there may be other co-receptors or auxiliary proteins that play a role in viral entry. So I wanted to take a few minutes to just go through what is known about the next steps of viral entry after ACE2 binding. Next slide. So after ACE2 binding, proteases activate the S protein, which facilitates viral entry into cells. This is thought to be either through an endosomal or a non-endosomal pathway, as shown here in this figure. It's believed that the major proteases that assist with viral entry are the cathepsin proteases and TMPRSS2. Next slide, please. So it's become clear that TMPRSS2 is, which is a membrane-bound cellular serine protease, is extremely important in allowing efficient entry of SARS-CoV-2 into cells. So the figure on the right is from a study of viral entry of SARS-CoV, so from several years ago. The authors here expressed various proteases on human ACE2 expressing cell lines, and they measured viral entry afterwards. In the presence of DMSO, which was acting as a control, viral entry occurred in all three cell types, which you can see by the black bars here. In the presence of a specific cathepsin protease inhibitor called MDL28170, only cells that express TMPRSS2 have efficient viral entry. Next slide, please. This figure was from the same study as in the last slide, and here the authors showed co-expression of ACE2 and TMPRSS2 in type 2 pneumocytes. So here the type 2 pneumocytes are labeled P2, that they're the cells labeled P2. And in the sections 2 and 3 respectively of the figure on the right, you can see specific brown immunostaining for TMPRSS2 and ACE2 within type 2 pneumocytes. Next slide, please. So the importance of TMPRSS2 has been highlighted by the effect of its inhibition on viral entry. So Camostat is a potent inhibitor of TMPRSS2. It's actually approved for pancreatitis in Japan. And in this study, authors showed that Camostat potently inhibits viral entry of MERS-CoV, SARS-CoV, and SARS-CoV-2, again by using the specific S proteins of these viruses. It had no effect on this control vesicular stomatitis virus on the left. So this drug is being studied for COVID around the globe now, although it's not available in the United States at this time. Next slide, please. But the story of viral entry is even more complex. And so in the last several weeks, a few papers were released that raised interest about the role that CD147 may be playing in viral entry. So CD147 is a membrane-bound protein that's part of the immunoglobulin superfamily. It was found to interact with SARS-CoV through cyclophilin A bound to N protein, which is another one of the viral structural proteins. So this figure here shows co-immunoprecipitation of cyclophilin A with CD147 on the right up at the top. And then below shows co-immunoprecipitation of the viral N protein with cyclophilin A. The authors here noted that none of the other viral structural proteins were found to bind to cyclophilin A. Next slide, please. So this is a schematic of the structural proteins of SARS-CoV-2. So importantly, you can see the S protein is at the surface, and the N protein here is represented in the core around the viral RNA. When the N protein is associated with viral RNA, while the N protein is associated with viral RNA in the core, some of it may relocate to the viral surface during maturation. Next slide, please. So this is, again, from studies from SARS-CoV. This is an electron microscopic image that shows cyclophilin A present at the surface of SARS-CoV. So the authors propose, based on the slides, the information we just discussed, that the interaction with CD147 for SARS-CoV was directly with cyclophilin A bound to the N protein based on all these data. Next slide, please. So recently, shifting back to SARS-CoV-2, recently what was known about CD147 and SARS-CoV led a group in China to investigate what would happen if CD147 were blocked. So what they show in the graph on this slide, they found that meplazumab, which is an anti-CD147 monoclonal antibody, significantly inhibited viral entry into cells in vitro. They also reported through co-immunoprecipitation that CD147 and the S protein interact. And again, note this is in contrast to what the groups that investigated SARS-CoV felt, where again they felt the interaction with CD147 was with the N protein mediated through cyclophilin A. And so this may need to be looked at more closely. Next slide, please. However, based on these in vitro data, a group in China designed a non-randomized trial with meplazumab to test its efficacy and safety as add-on therapy for patients with COVID. So they gave 17 patients meplazumab, as shown here, and compared to 11 concurrent controls. The baseline characteristics of the groups were similar. All individuals received lopinavir, ritonavir, and interferon alpha, and the distribution of steroids and antibiotics between the groups was similar. Next slide, please. So they showed that among this small group, those who received meplazumab were discharged faster, which is represented in the slide in the graph on the left, and that they had faster clearance of viral RNA compared with the concurrent controls, which is shown on the right. Next slide, please. So initially, the patients in either group were roughly evenly distributed between common, severe, and critical classifications of disease. Over 28 days, they showed more significant clinical improvement in the group that was given meplazumab. So this chart just looks at day 0 through day 28 of the patients who were initially classified as either severe or control, as either severe or critical. So for the control group, which is the bars on the right here, there were 7 patients who initially fit into these categories of severe or critical, and none were discharged at day 28. This is compared to, on the left with meplazumab, there were 13 of their initial 17 patients were in the severe or critical categories, and 9 of the 13 patients were discharged at day 28. So again, while these are certainly provocative data, this is largely hypothesis generating since this study was not randomized and in such a small sample size. Next slide, please. So just to summarize what we think is known based on this about viral entry. So again, ACE2 is an important receptor for SARS-CoV-2 viral tropism. The virus can infect and propagate in endothelial cells and kidney cells. Viral infections in other tissues likely requires infection of endothelium, followed by invasion of tissues because of virus size. And notably, while viral RNA was found in tissues outside the lung in SARS, for instance, there have not been enough path studies done to date on humans to know how often that's happening now with COVID. TMPRSS2 primes the S protein and allows for efficient cellular entry. And there's an interaction between the virus and CD147, the details of which are still being worked out. Many of these proteins are potential therapeutic targets and are under investigation at this time. And we do suspect we'll be hearing more about a lot of these in the weeks and months ahead. Next slide, please. Okay, so we're going to shift gears and give a brief update on the RAAS pathway and its relationship to this disease. Next slide, please. So we wanted to start by going through some older data that show that ACE2 is protective for lung injury. So here on the left, authors of this study show that loss of ACE2 worsens injury after acid aspiration in this mouse model. So lung elastance was measured for wild type and ACE2 knockout mice treated with either acid or saline. ACE2 knockout mice had increased stiffness of their lungs compared with wild type mice after acid aspiration, as you can see, which compares the blue squares to the orange squares on the left graph. On the right, the authors show that a sepsis-like lung injury is fatal for ACE2 knockout mice, whereas wild type mice are able to survive in this setting. Next slide, please. So this was an excellent review of this topic published recently in the New England Journal about what is known and is unknown about the interactions of ACE inhibitors and ARBs on the ACE2 pathway. And the authors, I think, importantly stress that much remains unknown at this time. So they note importantly that ACE2 degrades angiotensin II and attenuates its effects on vasoconstriction, sodium retention, and fibrosis. They note that ACE inhibitors and ARBs have different effects on angiotensin II, and therefore their effects on ACE2 might be different. They point out that there are conflicting data to date about whether these agents have an effect on ACE2 expression. And they note SARS-CoV-2 is thought to lead to downregulation of ACE2 expression, as you can see depicted on the slide here, which may worsen lung injury. Next slide, please. So here you can see the results of a small study from China of 12 patients that showed angiotensin II levels of patients with COVID were higher than for healthy individuals. This is shown in the chart on panel A there on the left. They also showed that among patients with COVID, higher angiotensin II levels were associated with higher SARS-CoV-2 viral loads, so lower cycle thresholds or CT values, and that's in the middle panel B. And on the right, they show that among these 12 patients with COVID, higher angiotensin II levels were associated with a lower P to F ratio, and they hypothesized that that higher serum angiotensin II levels may be an effect of the downregulation of ACE2 on COVID. Of note, ACE2 is known to play a role in ARDS even outside of COVID, and numerous previous studies have shown that other causes of pneumonia, including viral pneumonia that induce ARDS, are associated with downregulation of ACE2 and increased angiotensin II levels, and that ACE2 deficient mice, for instance, are more prone to serious lung injury in these settings. Next slide, please. So the question of whether ACE inhibitors or ARBs predispose to more severe COVID has not been answered by the large retrospective studies we have so far because of confounding and other biases. So this was a multi-center retrospective study from China that specifically sought to look at this question. So they included 511 patients with COVID-19. Of these, 78 had hypertension, and they stratified patients by whether they took no antihypertensives or whether they took ACE inhibitors, ARBs, calcium channel blockers, beta blockers, or thiazides. Overall, there was no statistical difference between the groups in terms of who developed severe pneumonia. However, among the subgroup of those who were 65 or older with hypertension, which included 46 of the patients, ARB use was associated with lower risk of disease, as you can see here. So this obviously a limited study with overall small numbers, but it's hypothesis generating, again, something important to follow. Next slide, please. So we're going to move on to talk about antibodies and immunity. Next slide. So this is a preprint from a group out of China, and these authors identified SARS-CoV-2 specific B cell responses and specifically isolated cells that recognize the receptor binding domain of the S protein of SARS-CoV-2, which again interacts directly with the ACE2 receptor. They obtained their samples from 8 patients with COVID. As you can see on the chart on the left, the authors identified these antibodies and plotted how well they bind to the RBD here. In the middle figure, they show that while these antibodies bind well to SARS-CoV-2, there's little cross-reactivity, at least at the RBD site, for the S protein of SARS-CoV, and they also showed to the S protein of MERS-CoV as well. So a neutralizing antibody needs to bind to the S protein at the RBD and also outcompete ACE2 while doing that. So on the right, you can see.
Aaron, in the meantime, while we're waiting for Eric to log back in, I did notice during your part of the discussion, someone asked the question of whether or not you had seen the recent paper from the 6th of April that showed 4 patients that wore surgical masks and cotton masks did not prevent the transmission of SARS-CoV-2 as detected by PCR. Did you happen to review that study? And if not, it's totally fine.
Yeah, no, I saw it. We didn't have a chance to address it here, but I think it was. I'm curious what other people think, but it was such a small study of 4 people,
Yeah,
and we're really they're measuring whether the virus could be identified on the kind of the reverse side of the surgical mask, rather than whether it reduces environmental contamination overall, which in my mind is sort of the goal of masks in general. So I wasn't too sure what to make of it, but I'd love to hear what other people think about it.
This is Raj. There was something odd where I believe they found virus on the outside of the mask more frequently than on the inside. At least that was one thing that raised some.
Yeah, which when I read that too, I was wondering, was there some sort of self-contamination, people touching masks and things like that? Hard to know, again, with that small of a study.
Yeah.
Eric, do we have you?
Again in a few weeks, you can see where that sits.
Okay. All right. So I might, I'm just texting with Eric. Hold on one second. Okay, so I might skip ahead to some other slides and then we can come back to Eric about some of the clinical data and all of this stuff. Okay, so, all right, so we'll talk a little bit about the cardiac injury and COVID, starting with 2 studies published in JAMA Cardiology on March 27th. So let me just minimize this. Okay, so this is the first study, which is of 187 patients with COVID-19 who were receiving care at one hospital in Wuhan. They stratified patients based on whether they had any elevation in troponin T or not, and elevation being here on the right. Unsurprisingly, those with an elevated troponin T were more likely to have a history of hypertension, coronary heart disease, cardiomyopathy, and diabetes. They were also more likely to develop ARDS, VTVF, coagulopathy, and kidney injury. In-hospital mortality was 60% in those with the elevated troponin T compared to 8.9% in those with normal troponin T. That is below the 99th percentile of the upper limit of normal. What is unsure, however, is whether elevated troponin T is simply a risk marker of severe disease, as we've seen in other type 2N STEMIs and other critical illnesses, or if this represents part of the COVID-19 pathogenesis. So interestingly, in this study, they found that troponin T was correlated with plasma CRP, suggesting the possibility of a link between myocardial injury and an inflammatory state. Excess mortality was most prominent in the group with both history of cardiovascular disease and an elevated troponin T, as seen in the top line, but was also substantial in the group without cardiovascular disease who had an elevated troponin T as well. This is the second study from JAMA Cardiology, which was a study of 416 patients with confirmed COVID-19 at a single center in Wuhan. 20% had cardiac injury, defined again as any elevation in troponin. Again, they found an association between comorbidity and cardiac injury, And they also found that cardiac injury was associated with death in this multivariable Cox regression model, as shown in the table on the right, with an adjusted hazard ratio of 3.41. This is a provocative case report also published in JAMA Cardiology of a 53-year-old previously healthy Italian woman who was diagnosed with COVID-19 and found to have elevated troponin T, CKMB, and NT-proBNP. Her ECG showed low voltage in the limb leads, here on the left, minimal diffuse ST segment elevation, and ST segment depression with T-wave inversions in leads V1 and AVR. Her echocardiogram showed diffuse hypokinesis with an ejection fraction of 40% and a small circumferential pericardial effusion. Cardiac MR showed biventricular myocardial interstitial edema and diffuse delayed gadolinium enhancement, all suggestive of acute myocarditis. She received dobutamine, hydroxychloroquine, lopinavir, ritonavir, and methylpred, and at the time of this report remained hospitalized with progressive clinical and hemodynamic improvement. This case thus represents the first report of MR findings in support of COVID-19 related myocarditis. Now, as possible evidence of a pathologic process underlying some of this injury, in this autopsy series of 3 patients from China, all 3 showed significant cardiac myocyte damage, including hypertrophy, degeneration, and necrosis. Figure A and B show hypertrophy and edema of the cardiac myocytes, and figure C showing some edema under the electron microscope. The figures below show some infiltrating inflammatory cells, primarily macrophages with a small number of CD4 T cells. There were similar findings in another autopsy study referenced down here below. Immunohistochemical staining and PCR did not detect SARS-CoV-2 in these cardiac myocytes. And unfortunately, there is little detail about the history and course of these patients, so these findings must be interpreted with caution. Eric, do we have you back?
Yeah, sorry about that. I lost power.
Go back to immunity. All right, go ahead.
Okay, so what I was saying was little cross-reactivity between the neutralizing antibodies that bind to the RBD of SARS-CoV-2 and SARS-CoV. And on the right in the figure here, what the authors were showing is a neutralizing antibody doesn't just bind to the RBD, it also needs to outcompete ACE2. And so what you can see on the graph on the right is markedly reduced ACE2 binding to the RBD in the presence of this neutralizing antibody, which is shown in the red line compared with the black line when ACE2 is there alone. And again, confirming that this particular antibody is neutralizing. Next slide, please. So there's been a lot of talk in the news about whether or not we'll have any durable immunity to SARS-CoV-2. And we just showed that people do make neutralizing antibodies to the RBD, which is an important step. This study shown here depicts 4 rhesus macaques that were infected with SARS-CoV-2 and who then developed detectable viral loads and even some symptoms, including weight loss. The viral loads declined and they eventually developed specific antibodies that were measured. 2 of the monkeys were re-challenged with SARS-CoV-2 and they did not develop a newly detectable viral load and had no change in weight or other symptoms, which was similar to a 3rd monkey that was monitored without re-challenge of the virus. So the authors suggest that while there are certainly limitations with the study and with extrapolating from these results, their results are suggestive of at least some immunity to reinfection. Next slide, please. So we'll cover some studies of some of the investigational therapies. Again, next slide, please. And this slide is, again, just to stress the importance of rational scientific information when making medical decisions. Next slide, please. So since we were talking about antibodies, just talking about antibodies, the first treatment we'll discuss, which has been in the news a lot, is the use of convalescent plasma. Again, this is an old technique where plasma is collected from a person who has recovered from a viral infection, who now has antibodies to that virus, and it's given to another individual who's suffering from the same viral infection. And these authors reported the first published series using convalescent plasma for COVID in JAMA. They administered the product to 5 critically ill patients. These are the donor criteria in the table here on the left. And they administered 400 milliliters of plasma from each donor to their patients. Next slide, please. These were the characteristics of the patients. And notably, again, they were all critically ill. They all had long illness courses prior to receiving the infusions with a median of 20 days into their hospital admissions. And the patients all had slow clinical improvement afterwards. Next slide, please. So this study describes another 10 critically ill patients who received convalescent plasma and did well. They were given one dose of 200 milliliters of plasma from recovered donors who had neutralizing antibody titers greater than 1 to 640. The patients received infusions at a median of 65 days, of 16.5 days into their illness course. Clinical symptoms improved over time with clearance of viremia from 7 out of 10 patients who had detectable SARS-CoV-2 RNA in their blood at the time of the infusion. Additional studies have now been published as well. All of these data have been in series without controls, so the actual efficacy remains unproven. And all of the patients who've received convalescent plasma have been critically ill, and so it remains unclear how this treatment modality will be deployed for COVID, and specifically at what stage of disease it will be most beneficial. But it is actively being studied. It's believed that high neutralizing antibody titers in donors will be important, since lower titers might cause enhancement of viral entry. Next slide, please. There continues to be a lot of interest in the IL-6 pathway and the hyperinflammatory second symptomatic phase of COVID illness course. So a German group analyzed data from 40 consecutive patients with COVID admitted to their hospital. Of these, 13 or 32.5% eventually required mechanical ventilation. The time from admission to intubation varied from 1 hour to 9 days, with a median of 2 days in this cohort. The authors found that elevated IL-6 on admission was associated with poor outcomes. A cutoff IL-6 level of 80 picograms per milliliter in this group on admission had good discrimination between those who eventually required mechanical ventilation and those who did not. Additionally, we wanted to mention a small Italian series of 21 patients treated with siltuximab, which is a direct IL-6 blocker. That's in contrast to tocilizumab and sarilumab, which are IL-6 receptor blockers. So the preliminary results of this siltuximab study were not overwhelming. 33% had some clinical improvement, 43% showed stability, and 24% experienced clinical worsening. They'll report more on this cohort as they gather more data. Finally, there are frequent case reports and surely to be more case series of tocilizumab that are reported now, and we've pasted a few of these references at the bottom of this slide. Next slide, please. So just a quick update on the data related to hydroxychloroquine. So this is a reminder of where we were 2 weeks ago. And the biggest update is that this small French study that was a non-randomized study that had suggested faster viral clearance for hydroxychloroquine, the society that published this did release a statement a few days ago saying that it did not meet their standards. Next slide. So additionally, since last time, there was another small randomized controlled trial in China that looked at hydroxychloroquine versus no hydroxychloroquine for mild COVID. The table of the characteristics of each arm are shown here on the left. They found that resolution of cough and fever were faster in the hydroxychloroquine arm, but there were some important limitations to the study, including that it excluded 80 patients, but the reason for the exclusion is not clear. And second, standard therapies were allowed in each group, and they note that these include steroids, antivirals, and even IVIG, but it's not clear how these were distributed between the groups. It's also not clear that the endpoints they looked at are meaningful, and there's no data that they report about discharge, mortality, and other virologic markers like viral clearance. Secondly, the French group that had released the study that's now been criticized did release another report of 80 patients with mild COVID that were treated with hydroxychloroquine and azithromycin dual therapy. And overall, the patients were admitted with an average of 5 days of symptoms. 93% had day 8 negative RT-PCR from the nasopharynx, and 81.3% were discharged at the time of writing the report. And they note the average hospital length of stay was just over 4.5 days. This study, too, obviously has a lot of limitations since there's no control arm. Next slide, please. So the hydroxychloroquine and azithromycin report that again has now been criticized by the publisher. Another French group in Paris studied this combination in 11 patients with COVID, and they found that 8 out of the 10 who were alive at day 6 remained PCR positive. This casts further doubt on the original report, remember in that original report, the authors reported that 60% of patients on hydroxychloroquine had day 6 viral clearance, compared with under 15% of controls. The table here on the right is from an earlier RCT that we discussed last time, which again, also just to point out that this did not show a statistically significant difference in viral clearance at day 7 from a throat assay. Next slide, please. So this is where we were with favipiravir last time, which again is an RNA polymerase inhibitor. Next slide, please. And favipiravir was just approved by the FDA to undergo trials in the US, and those will be opening shortly. So this is a slide from a preprint of a large open label randomized controlled superiority trial from China that compared favipiravir to umifenavir, which is also called Arbidol, for patients with COVID. They randomized 240 patients 1-to-1 to receive these treatments. All had symptoms for less than 12 days, and they received 7 to 10 days of the medication according to the arm they were assigned. Clinical recovery was defined as afebrile, normal respiratory rate, and SpO2, and resolution of cough. More than 80% of patients in both arms were classified as moderate severity at the time of enrollment. And moderate was fever with lower respiratory findings, but with a respiratory rate less than 30, an SpO2 greater than 93% on ambient air, and a P to F greater than 300, and without, quote, rapid progression of imaging findings. So overall, the results showed a clinical recovery rate at day 7 that was not statistically different between the groups. So 52% at day 7 in the umifenavir group showed clinical recovery, and 61% in the favipiravir group. When they looked at just the moderate patients, which again were the majority of the patients, more than 80% in each group, so the day 7 recovery rate was 56% in the umifenavir group and 71% in the favipiravir group, with a p-value around 0.02. Additionally, the time to fever and cough reduction was shorter in the favipiravir arm. Both agents were safe, although the authors noted there was more elevated uric acid in the favipiravir arm compared to the other arm. The major limitation of the study is that the major finding was not a pre-specified subgroup, and it wasn't corrected for multiple testing. And so again, we think this should be considered hypothesis generating. Next slide, please. So there's a growing realization about the importance of hypercoagulability in COVID, and as well as C. Next slide. So there have been a couple of recent studies that have focused on the prognostic value of abnormal coagulation parameters in COVID. So this paper included 183 consecutive patients with COVID at a hospital in China, of whom 21 died. They found prolonged PT, elevated D-dimer, and an elevated fibrin degradation product were all associated with death, as shown in the table on the left. They also found of 71% of patients who died, and just 0.6% of survivors met the International Society of Thrombosis and Hemostasis criteria for DIC during their hospitalization, and those criteria are shown in the table on the right here. Next slide, please. So the same group published a subsequent study where they analyzed 449 consecutive adult patients with severe COVID-19 admitted to one hospital in Wuhan. The median age was 65, and 61% had comorbidities. Of these patients, 22% received some form of anticoagulation for at least 7 days, and all of these were a prophylactic dose of anticoagulation. So the vast majority received enoxaparin at 40 to 60 milligrams daily, and a few received unfractionated heparin at a standard prophylactic dose. In the cohort, 30% died, and there was no difference in 28-day mortality between the heparin users and the non-users. However, they found elevated D-dimer, prolonged PT, age, and low platelet count all correlated negatively with 28-day mortality, as shown in the table on the left. So on the right, the figure on the right, they stratified by D-dimer, and so they found that for those who received prophylactic anticoagulation with a D-dimer greater than 6 times the upper limit of normal, there was a 20% reduction in mortality. And again, in this chart, heparin users are in blue, and non-users are in red. It's important to stress that this was not a study of full dose anticoagulation, although that is likely going to be studied. and there was no cause of death specified for those who died. Also, again, the subgroup was not pre-specified, but certainly as we are seeing a lot of thrombosis and markedly elevated coagulation parameters, this is extremely important to be following closely. Next slide. So there are not a lot of published path studies, as Aaron mentioned. This is from one of the studies that he had mentioned in relation to the when he showed some cardiac path earlier. And again, this is a study. There were 3 patients included in this study from China. They didn't specify their clinical course or the cause of death, but they did show that there were microthrombi on path in many organs, as depicted here. And again, just to stress that this is an important area to follow. Next slide.
Okay, we're going to skip ahead past this. Okay, so just now one slide on anosmia aeguzia, which have been heavily featured in the lay press the last few weeks as a result of society statements from ENT UK and the American Academy of Otolaryngology Head and Neck Surgery that have said, quote, that anecdotal evidence is rapidly accumulating that anosmia may be a presenting symptom of COVID-19. This is supported by this preprint, which found that olfactory epithelial cells do indeed express the target receptor of SARS-CoV-2. However, as far as we could find, there is little actual evidence beyond clinical anecdotes that are highly subject to recall bias that anosmia is actually an important presenting sign of COVID-19. The only weak evidence we could identify is from this online tracker in the UK, which suggests that among individuals with sufficient symptoms to have a PCR test, the prevalence of anosmia was 3-fold higher in those testing positive than in those testing negative. So I think, you know, there's more to come in here as far as the importance of anosmia. So in the next section, we'll discuss some age-specific considerations for COVID-19. This first study is a preprint that was posted by a modeling group from the London School of Tropical Medicine and Hygiene on March 27th. In this study, they test 3 hypotheses that could explain the differential age gradient of clinical disease observed in COVID-19, 2 of which I'll highlight here. First, though, this figure on the left represents susceptibility to infection by age, and the figure on the right represents the clinical fraction by age, with clinical fraction meaning the percent infected who will become symptomatic. Their first hypothesis, as depicted in the orange line, is that there is age-varying susceptibility to infection by SARS-CoV-2. This could be explained, for example, by immune cross-protection in children through recent infection with other coronaviruses, for example. The other hypothesis is that children are as susceptible as adults, but much less likely to have symptoms, meaning that there is a lower clinical fraction in younger people, as depicted in the blue line in these figures. When they modeled these 2 possibilities using the data from Wuhan, the second hypothesis was best supported, that is the one in the blue line. This was further supported by regional contact tracing data, and the resulting model was largely able to reproduce the age distribution identified in other cities in China, in South Korea, and in Italy. They then used setting-specific demographics and contact matrices to estimate age-dependent clinical proportions in various regions, as shown here in this figure, with an estimated 20% of infections in children under 10 resulting in clinical cases, rising to over 70% in adults over 70. Finally, they used their model to try to determine the impact of school closures, which will depend on the fraction of the population that are children and the contacts children have with other age groups. They looked, for example, at 3 cities with different demographics: Milan, with a high median age on the left, Birmingham, UK, with an intermediate median age in the middle, and Bulawayo, Zimbabwe, with a lower median age on the right, and then used measured contact matrices for each of these 3 countries to determine the impact. So they looked at varying levels of assumed infectiousness of subclinical cases, 0, 0.25, 0.5, and 0.75 times the infectiousness of clinical cases, and found that the impact of school closures, which are depicted by these dashed lines, tended to be greatest in the older cities and when subclinical infectiousness was highest. A study recently published in Science that we referenced in the last presentation suggested that the infectiousness of subclinical cases was likely to be around 0.5 times that of symptomatic cases. So this line may be closest to what we would expect. This is another preprint. Let's see if I can, there's no, there we go. This is another preprint from a group at Harvard and MIT that was posted on March 31st. that evaluated age-based sheltering strategies. They used a stochastic, agent-based, susceptible, exposed, infectious, removed model for SARS-CoV-2 and included a number of important parameters within the population-specific demographic structure, including distributions of age, household structure, contact across age groups, and the comorbidities, hypertension, and diabetes. Their model assumes that individuals at all severity levels could transmit disease, but that those in the asymptomatic state do so at a lower rate, again, based on the science paper previously referenced. They incorporated the possibility of an isolated state and divided the contact structure into in-household and out-of-household groups, with transmission rates higher within households. They used this to model the epidemics around Wuhan and Lombardy. They used this model then to evaluate the effect of various mitigation strategies in Lombardy, in particular, the effect of sheltering specific age groups. In the left figure, you can see the substantial reduction in infection with sheltering of 50% of all ages at 50% in light blue and at 100% in pink, but that there is minimal reduction with isolating only a particular age group. The right figure is a similar concept, but with total deaths. Here, though, they look at the combination of age-based sheltering and physical distancing of the rest of the population. And you can see that with physical distancing, sheltering of a single age group is able to substantially reduce infections and deaths compared to physical distancing alone. So in this last section, we wanted to highlight some studies focused on seasonality, surveillance, and contact tracing. First, seasonality. There continues to be this idea thrown around, particularly in the lay press, that SARS-CoV-2 is likely to dissipate come summertime. This is a relatively straightforward preprint from the Center for Mathematical Modeling of Infectious Diseases that was posted on March 25th and shows at the top a map of the world with countries depicted by WHO SARS-CoV-2 transmission status. Imported cases in orange, confirmed local transmission in purple, under investigation in white, and no information in gray. The figure at the bottom left shows figures with imported and local transmission by mean temperature, and the figure on the right is by mean relative humidity. They note that all WHO regions have at least 6 countries with confirmed local transmission, effectively spanning all climatic zones. These countries depicted with the plus sign are those with local transmission and an average temperature above 25 degrees Celsius with relative humidity above 70%. This suggests that seasonality should not be considered a key modulating factor in transmission, although it does not rule out slight reductions with warmer weather. There have been a series of studies, as shown on this slide, in the last few weeks that highlight the important role that sentinel surveillance can play after mitigation efforts. For example, this MMWR study here concerns sentinel surveillance in early March in Santa Clara, California, after identification of a case associated with probable community transmission. During an 11-day period, they tested people presenting with respiratory symptoms at 4 urgent care sites with no known risk factors for COVID-19 who had tested negative for influenza. 226 people met the initial inclusion criteria, of whom 23% tested positive for influenza. 79 of the remaining samples have been tested so far, and 11% were positive for SARS-CoV-2. As a result of this surveillance, early community mitigation measures were initiated in the region, and this may in part explain the different trajectories of the epidemics in California compared to the other areas of the country that instituted mitigation efforts later. This is another strategy for community surveillance that has been proposed, taking advantage of the shedding of SARS-CoV-2 RNA in the stool. This is being tested by a group in the Netherlands, among others, that has previously used this strategy to monitor for norovirus and measles, among other pathogens. They were able to detect SARS-CoV-2 RNA in wastewater only 4 days after the Netherlands confirmed its first case, and have now expanded sampling to the rest of the country. Finally, a word about contact tracing. This is a study that was published in Science on March 31st. This group used a susceptible, exposed, infected, removed model that divided transmission into symptomatic transmission, pre-symptomatic transmission, asymptomatic transmission, and environmental transmission. Based on literature that we've previously described, they used a doubling time of infections of 5 days and an incubation period of 5.2 days. They also used a detailed set of transmission pairs to estimate the probability of pre-symptomatic transmission. They then used this to model the impact of 2 interventions. First, the isolation of symptomatic individuals And second, the tracing of contacts of symptomatic cases with subsequent quarantine of these asymptomatic contacts, with the goal of stopping the spread of virus from both symptomatic individuals and their asymptomatic contacts, while minimizing the impact on the larger population. In the figure, you see that the red areas represent conditions where the epidemic will grow, and the green areas represent conditions where the epidemic will decline. The black line shows the threshold for epidemic control. The x-axes are the success rates of case isolation, and the y-axes are the success rates of contact tracing. The leftmost figure represents a 3-day delay from the identification of a case to the tracing of their contacts. The second figure is a delay of 2 days, the third of 1 day, and the rightmost figure is with no delay. This model highlights that with substantial delay between case identification and contact tracing, these interventions are very unlikely to be effective at controlling the epidemic by themselves. But if there is little or no delay, epidemic control can be achieved even with relatively lower rates of case identification and contact tracing. One solution they propose to allow for extremely rapid contact tracing is use of a mobile phone app to allow for digital contact tracing by keeping a temporary record of proximity events between individuals. Similar apps have been reported in China and South Korea, but have been criticized for issues of data protection and privacy. The authors note that this approach would not require coercive surveillance, since the system can have very large impacts and achieve sustained epidemic suppression even with partial uptake. This may be a promising strategy to be used once mitigation strategies are successful in a given region. So, in closing, these are some of the major takeaways we want to highlight from this update, including obesity as a risk factor for severe disease, the emerging importance of hypercoagulability and cardiac injury, the possible utility of age-based sheltering as a complement to physical distancing and mitigation, and that minimal or no delay is essential for contact tracing to be effective. And so, sorry, went over a little bit in the setting of our power outage, but I'll take a quick look at the chat here to see if there's any questions. So we have a question from Seth Bloom. Did they wear the masks backwards? I hope not, but I don't know if anyone else has any insight into that one. And there's a link here about an opinion piece on hydroxychloroquine and a data review at the things we should stop recommending its use as ID consultants, which I don't think is unreasonable. Let's see, the study excluded anyone discharged in less than 7 days. There's some additional sort of details about, some issues with the heparin study. I mean, I think that clearly we need to see a lot more on that. And then a couple preprints posted about olfactory changes. Any other comments from anybody or thoughts? Okay, thank you very much. And sorry to go over a little bit.
Thank you.